So, hello everyone, and welcome back to ImmunoLogic, the podcast where we take the cutting edge of immunotherapy and hopefully splice it into real world clinical insight with just enough humor to keep the neurons firing. And I'm Joe Fraietta, your ever immuno obsessed host. So, today we're going to talk about neuroblastoma and specifically the high risk disease where the treatment roadmap can sound less like a regimen and more like oncology sort of like refused to leave any weapon in the arsenal. So there's induction chemotherapy, surgery, radiation, transplant, and what we'll really get into and unpack with our special guest is anti-GD2 immunotherapy. It sort of sounds like spa medicine to me, but the question today is not just what's new. It's what's actually changing. So are we simply stacking smarter therapies on top of an already, I don't know, I would say punishing backbone? Or are we finally learning which parts of the old playbook we might be able to retire? And I'd like to introduce Janna Minehart, my clinical co-host and collaborator, right, Janna?
Yep.
You excited for this
Good to be
episode?
here. Yeah. It's great to
Yeah,
have our
great.
guest.
Great. And to help us unpack all of that, it's my great pleasure to welcome Dr. Kristopher, or Chris with a K, Bosse. And he is a dear friend. I'll get into all of your credentials, Chris. And he's also great if you have a grant that you need like edited. And, we go to a weekly meeting together. And he's always the first to say, like, I don't get what you're doing. Like, state it simply. So I appreciate that, Chris. But seriously, so Dr. Bosse is a pediatric oncologist and a physician scientist at CHOP, whose laboratory focuses on new immune-based therapies for neuroblastoma specifically, including GPC2-directed strategies. And also, Chris, I read some more of your work, liquid biopsy approaches to track tumor evolution. So welcome to ImmunoLogic.
Thanks for having me, Joe and Jan. This will be a lot of fun, so I'm excited.
Yeah, it will be. So why don't I dive right in? So for listeners who know neuroblastoma by name, but not necessarily by lived clinical reality, Chris, maybe you could set the stage for us a little bit. So why has high-risk neuroblastoma remained such a stubborn problem, even as the field has clearly improved over time?
That's a good question. So I was lucky to train in the lab of John Maris, who who's
Yes.
renowned expert in neuroblastoma. So I learned a lot over the last decade. And kids with high risk disease are getting more and more. We're stratifying that out further, so they're not all the same. But the crux of it is about half of them ultimately end up dying from their disease. And when you relapse after that initial regimen you mentioned, which takes about 1.5 to 2 years of every type of anti-cancer therapy you can think of, you're almost 100% gone. You almost incurable at that point. So that's why we continue to focus on this in the lab, and thankfully it's rare, like all the other pediatric tumors or pediatric solid tumors for sure. So, but still a big problem in our world, and a lot of kids and families come here from all over the world to get treated at the time of relapse. So, I think it's the right place to do these early phase trials and try to make a difference and move the needle.
So
Yeah, no, absolutely.
what's the current status of our favorite kind of therapies, like, immune-based strategies in neuroblastoma?
Yeah. So, for decades, GD2 has been known as a target. It's a sugar on probably all neuroblastomas, but it's a hard thing to quantify because you can't do immunohistochemistry because it's a sugar, and we don't do flow cytometry well in the solid tumor world. But it's on most neuroblastomas. How it sort of changes over the course of therapy is just something we're beginning to learn, despite 30 years of being targeted. And so for a long time, there's been antibodies in the blood of patients with neuroblastoma, but also other cancers. And, not that long ago, there was a paper in, so I was training in 2010, which was a sort of landmark study to get tuximab, which is a chimeric GD2 targeting antibody, into the clinic as a phase 3 trial, showed, a better control in the what we call the maintenance phase. So it's the end of therapy compared to the standard. And it's the first FDA approved drug for this cancer. So it's kind of crazy to think about that. Um, and so that's really was our sort of first immunotherapy, if you consider an antibody immunotherapy, which I do. And that's now moved really is the first line of relapse with chemotherapy. So we give irinotecan and Temodar and dinutuximab for as a first line of salvage, which until a handful of years ago was really we just did a bunch of different things that relapse, but that's really become the standard and does is quite active, but again most kids eventually will relapse, unfortunately. So that was the current state, and then for years and years people have been trying to target GD2 with CAR T cells, and I think there was some signs of efficacy. But really not enough to move anything forward. And I,
I think it's probably most famous for the that construct that unfortunately had the tonic signaling problem.
yeah,
Oh yeah,
right.
right,
That's right when I actually started thinking of CAR T cell. So, so there was that, and there was a lot of other ineffective constructs and earlier generation constructs, and just recently the Italian group published a paper in the New England Journal showing, I think, really the first proof of really durable efficacy in patients with neuroblastoma and GD2 CARs. It's a third generation CAR. It's a bit hard to understand to get through all the details of that paper, but surely it's active, and where we go from there, it'd be hard. I'm not sure, but
so could I step back for a second, Chris? So GD2 directed therapy, because I know very little about this, but do you think it should stay mostly in the, I guess, as you alluded to, like in the post-consolidation space, or, do you think it belongs earlier?
uh, yeah,
More like a frontline therapy? Can we use, those therapies more strategically? So do you think appropriate for the frontline setting, or any folks studying that really?
yeah. I mean that the trial from the Italian group showed
Oh,
very
that's what you're talking
clearly.
about. I'm
Well,
sorry.
they showed very clearly that it was better. That car at least was better for patients with less disease burden, right? Which I don't know. In retrospect, isn't that surprising? Trying to think that
Same
we're
in
gonna,
lymphoma.
right? Yeah, think we're gonna treat bulk disease with, I think that's asking a lot of the T cell. I think we can get regressions, but I'm not sure we're gonna put those kids into a complete remission. But yeah, I think we have a lot to learn. There's such heterogeneity in the world, right? And you asked about neuroblastoma. I think that's part of what makes this tricky is high risk. It all sounds the same, but it's so different. And you've seen this as we've talked a little bit about the trials ongoing here, and it's just a
Right.
heterogeneous disease, and every patient is very, very different for multiple factors. So it's really hard to understand these different trials, CAR T cell trials over different decades at different institutions with different products and different manufacturing, right? So I think we have to get
Right.
them.
So I guess in terms of the more like the standard of care now, I'll ask you a mildly uncomfortable question that I alluded to in my intro. Are we replacing toxicity, or are we just becoming more sophisticated at piling therapy, on
Yeah.
top of therapy?
Yeah.
What do you think about that? Can you unpack that a little bit?
Joe's a good host here.
I don't know about that. I'm
Made
I'm
for
good at
podcast. No, I
listening.
like that. I like the. I didn't answer your last question. I think it's similar. Where to right. So in leukemias, and I'm not a leukemia doctor, but right now moving it further up in the treatment program, blinatumomab's given for kids very early, right?
Mhm.
So um, we haven't clearly gotten there for the adults, right? But you have to imagine that there's a place. If if a patient, let's say with neuroblastoma, responds to the induction chemotherapy and gets into a CR, there's a place in.
Mhm.
I still think consolidation, but earlier in consolidation, not consolidation once they relapse 4 times. I think there is a place earlier, but it's going to take like all of this years of trying to study and trying to move this into large phase clinical trials, and I think it's tricky with such a I'm thankful that it's a rare disease, but it's tricky because you have to really choose one thing to study or two things to study, right? And how many different CAR T cells are there for neuroblastoma, right? So like, how do you choose? And we all have our favorite targets and CAR T cells. So, I think it is very complex and I think it's easy enough to convince yourself to do a phase one and the patients who have no other options, but then really moving it up front is a much more complicated process, of course. So, but I think that's where you're going to see really maybe see a benefit. Um, I do think it's safer than cytotoxic chemotherapy at some level, but there's other risk, right? And especially kids with a lot of disease and antigen burden, and we've seen that too, right? So,
Right. I didn't mean to imply that, additive is meaningless, right? It's certainly not.
Oh.
And you also brought up, classic chemoimmunotherapy, and I was doing some research for this episode, and it seems that radiopharmaceutical therapy is getting pulled back into the conversation, although this seems like a little bit old hat. But there was recent phase one data, and I'm sure you're very much familiar with this, with Janna, help me, dinutuximab with or without verinostat, and there was like a 40%.
No, MIBG. You're thinking of 131.
Or am I thinking of something? Yeah, 131. So, what do you think? Like even the old neuroblastoma workhorse, which it seems this is being invited back to the immunotherapy table. Are you a believer or what?
Yeah, I think you think it's old because it takes so darn long to study these things. So it was just in a phase 3 trial, and we don't even know the data from that. But that you're referring to an earlier phase trial, which showed good efficacy. But no, it's one of our mainstays of treatment at relapse. So kids get a chemoimmunotherapy, which is dinutuximab plus chemotherapy, and then very likely will get MIBG radiotherapy if they have MIBG avid disease. So, it's nice you can actually give it's like a PET scan, right? So an MIBG scan, you can see uptake, and then it's a good biomarker for taking up the radiotherapeutic. So yeah, we use that all. And again, it's not as old as dinutuximab, and there's challenges in manufacturing it, and just unfortunately only one place I think in the world that makes it. But it's very active, but it's like anything else. Kids respond, but then unfortunately relapse. So it's not I think it's like all cancers, right? They're so creative in terms of how they get around therapies, and so that's why all this stuff is built into neuroblastoma. Because if you just do one thing, even if we do everything, it's still it's just again, they're just smart diseases, unfortunately.
Yeah. Can I ask a very in the weeds question? What are these kids' counts like? Because it sounds like I know peds, they're little rubber bands, they spring right back, but it also sounds like these kids are getting really intensive, induction chemotherapy means, chemotherapy again with relapse. And I just, it's something we think a lot about in lymphoma in terms of optimal sequencing of therapies, or thinking more about now, like the utility of giving lymphotoxic chemotherapy when subsequent lines of therapy require an intact immune system.
Yeah. Well, the first part of what I tell every family when we're going neuroblastoma or whatever therapy regimen we're talking about, that it is amazing. Kids are quite resilient, and on themselves and their counts. So I think
the patient and their marrow
and their marrow. So that's that's why we can do what we do, because most kids do well, and they actually surprise you, and I can go on and on, but the great stories, but that's why it's not all gloom and doom, and the kids actually are the most impressive part of all of this, right? But you're right. You asked multiple questions. So one is, there is a point, especially in neuroblastoma therapy, where they'll never recover their platelets, for instance, right? Kids will live with platelets of 40,000 or 50,000, and it's largely fine. They get a lot of transfusions, but so there is a marrow limit to especially as some of these kids have, it becomes much more of a chronic disease, so they get treated and they stay with, they sort of live symbiotically with some low level disease in their body and get therapy, and then their counts eventually will tank and not recover too quickly. The immune question is right, and that's a huge point that I think we're learning is when you for T cells after 10 years of cytotoxic therapy, like some of them might be okay, but and Joe, I have to get you these cells. And remember, we were going to learn about all these products, but right. So,
We
but some
will.
are terrible, right? Some are terrible, and we know that. It's not surprising, but so thinking about like how do we, sequence this, and we need to collect T cells earlier, and we, for neuroblastoma, we collect stem cells after 2 cycles of therapy, and it's because they get 2 auto transplants with Joe's, went through that. So they get 2 auto transplants where they get stem cell rescue, and sometimes they get rescued post MIBG because it's so cytotoxic to your marrow. So
has anyone made a T cell product from?
yeah, so we're trying that. It's not as good because they're stimulated differently, of course. But we have now done for patients where you can collect both, collect T cells first, stimulate for your stem cells, and then collect stem cells. It's a little more cumbersome in time in the hospital with these big, pheresis catheters for the kids, but that makes sense, right? And that may be a huge difference. So, these later collected products just aren't, it doesn't matter if you have a perfect target and the right amount of disease, but it's just not good T cells. So, I think that's something we have to get smarter about. But, we're at least, especially here at CHOP, we're just getting into this and learning. And I look forward to emails from Joe's group because every time we learn some correlative data, we get some correlate, we learn something. And so I think we have a ways to go. But that's it's a big problem. And there was a paper out of CHOP a few years ago that showed just that the T cells are post chemotherapy in any oncology patient, pediatric patient, are terrible. So sure, the same as in your world, right? Or do you freeze patients earlier? Or I don't know. No.
No. Still burdened by, disease, treatment indications and
Yeah.
insurance approvals and things like that.
Yeah.
It would be lovely if some massive benefactor wanted to fund us to, collect T cells on everybody much earlier
I
on.
think because we're
Don't
already
they do that at CHOP?
what?
I don't think we can
Well,
afford it here across the
No,
street.
we have the catheter in these patients, so I actually think it takes away a lot, right? They're in the hospital, and yeah, it's more days, but again, like, are we free? Like, if we're really going to prove to ourselves that these kids are going to get CAR T cells at some point, whatever they may be, then that makes sense, right? But a lot of these patients, they won't, and so I'm not sure insurance companies love that.
Yeah.
We sort
Feasibility.
of covered. Oh, go ahead.
No, just feasibility always the
feasibility, and it's complicated, right? So we covered GPC2, or I guess for our viewers, I should spell it out. So Glypican-2, and that's what I think of, Chris, when I think of you, and John, I suppose, because you really,
it's fun.
Honestly, you and your colleagues really helped establish it as a compelling neuroblastoma target. So I have a question about the biology. I remember when I first read, your paper, and you mentioned early on in this episode that it's robustly expressed on the surface of neuroblastoma. It also appears to matter for tumor biology, which is not true of all of the things that we target. I could tell you that part of the problem. Of course, it's not expressed at significant levels on normal tissues, but it's also enriched in the tumor stem cell compartment, which I think makes it or is that controversial? But I mean, it just seems like the perfect target. And you alluded to the heterogeneity, which is true, right, in many tumors. But can we get into this a little bit? So what do you think? Is it the tumor that's evolving, under selective pressure? Or is it the initial baseline heterogeneity, or both? What do you think?
Why, if you see,
why do you get a is one perfect target enough? Right, it's the age-old question, even if it looks as good as GPC.
I don't think one target's enough, and we're learning this, right? And I think if you have a good enough CAR T cell and put enough pressure on a tumor in a patient, then you will get antigen loss. And we when we started this project, when I was a postdoc in John's lab, and it sounds so trivial now, but the whole goal is to find these differentially expressed molecules on cells, and
Right.
the tumor necessary, right? And the tumor can live without them. And, coming from our, cancer biology background, and that is true of GPC2. We've shown that, other people have shown that. But what I didn't realize at the time was, tumors can downregulate a protein to some level, escape carb pressure, right? But still have enough to, do whatever biology is important. And so, we see this in mice, and we're starting to see this in humans, where you can get down regulation, but it's not gone. It's just lower. And, the CAR needs a
Right.
lot of antigen, right? And, I think also thinking about how much antigens in the CAR need to proliferate, but how much does it really need to synapse and release all granzyme and all these things? And actually, I was just having a discussion with Evan Weber in the hallway yesterday about the same point, right? So there's probably different levels of threshold. And, the tumors are smart. So they select for cells that have less. And we don't know if it's active or passive or, selection, but surely, I think that's going to be seen with any potent CAR. And, the GD2 folks say, well, we don't see loss, but, if you really look at that data, it's impossible to know. And, so I don't want to make sure the samples are paired samples or not. So,
Right.
I think it's going to be right. It's going to be a thing. If you don't have an effective CAR, then yeah, you don't see loss, right? Because it
Right.
was pressure. So I do think dual CARs or however you want to target multiple antigens will be important. It's not going to solve everything, though.
What other antigen would you
One
combine
hurdle.
with
What's
GPC?
that?
Right.
What other antigen targeting would you combine with GPC2?
Well, that's
Two or something
what's
something new
that?
and different?
Yeah. I mean, I think um the thing we think a lot about is tumor biology. So, we come at this from I'm not a T cell immunologist. I don't really care about T cell exhaustion, although I know it's important. But
You're hurting my feelings.
Janna, yeah. But we come at this from tumor biology. So I think one thing we think a lot about is the native heterogeneity of tumors and neuroblastomas, and there's been well-characterized different cell states. So I think targeting both cell states is important. We have some work. That shows that potentially is effective, but surely you need more antigens. But I think, what happens to a T cell or a cancer cell after you put on, let's just say, GPC2 or GD2 CAR pressure, and no one really studies that. The tumor relapse, and we don't look at it. And so I think we're trying to do the studies. They're not trivial, but trying to learn as much as we can, both from the preclinical work and the clinical. But I think dual antigen targeting, but that's not going to be enough. You'll get better potency, right? But there's lots of T cell biology, armoring, tumor microenvironment. You know, it's
Yeah, you have an interesting
uh,
paper, the bispecific innate cell engager.
oh
Is that,
yeah. Yeah.
a
Cool.
combination? Was interesting to me.
Yeah.
Do you think that there's is there something specific about neuroblastoma that 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 makes that a rational combination, or is it kind of applicable to many solid tumors where we think that, additional innate immune system,
Yeah.
engagement would be beneficial for CAR and,
Yeah. I mean,
other cell
that
types?
was done by Guillaume Pascal Pesto, who's this wonderful, my first postdoc in the lab, and he was great. He's back in Spain, started his own lab just recently, and he came in my office one day and said, "I want to do this." And he actually was copying the car bite that you guys made over at Penn, that concept. And he said, "I want to do this as a bike." And the rationale was, we know that neuroblastomas don't have many native T cells. And why the heck do you want to bring more T cells? And you're doing that with the CAR T cell, right? So he thought, and it was also just different, right? So the novelty of a different approach. So I do believe in it. I think what we always struggle with that work is the in vivo studies are really hard to do, because you're giving, right, these are NSG mice with human tumors, human T cells, and then you give them NK cells or CD16 enriched PBMCs, and those aren't trivial. It takes a lot to get those cells, number one, but thankfully we have the nice core facility, of course, and but then they don't last very long. And so do you really see the benefit of um, the innate cell engagement, whether it's NK cells or macrophages? So I don't think we fully appreciate even now that how much enhanced efficacy you could see. So I do think you got to just do that in the fully mirroring system, which has its issues too. And the bit of the problem there is CD16 and mirroring. There's one isotype on macrophages and one on NK cells. So you, in a way, which is kind of cool because you could separate the effects, but it gets complicated. So we have those binders actually, and we just haven't done the studies. But whether that's the next approach and that's a dual targeting approach, is it better than a native bicistronic CAR or dually transduced T cell. Yeah, I don't think we know that yet, but it is a cool approach. Everyone likes that. It's funny. But yeah, no, I believe I think we struggle with the last part of that paper where the efficacy was better, but it wasn't as is it good enough to really move that forward? I think something we
Yeah,
see.
we lack good models, certainly for kind of more complex or
Yeah.
not even more
Yeah.
complex, but just moderately complex immune system modeling is pretty
Right.
challenging.
Right.
And
Yeah.
I'm sure too, with multiple solid tumor CARs having perhaps more ICHS, than certainly we see in the CD19 lymphoma world. I wonder too about potential toxicity with.
Yeah, I don't know if that's been true. Surely we see it in solid tumors in kids, but I don't know if we don't have as much experience as you do. But I don't, again, there's such heterogeneity. It's hard to really say that that's a common complication. And yeah, it's the meaning of CRS or ICHS in a solid tumor patient or even the meaning of peripheral CAR T cell abundance. I don't really know what that means and whether it matters or not. And right. Um, and really what matters is what gets to the tumor. And so I think we're learning again. I don't joke every day when Joe's group sends us data. We learn so much because I just, I think it's not CD19 leukemias, which is what we do here very well. So yeah, we'll get there maybe eventually. Or not, right? I mean, we do ask the question. Well, I'll just say it: are CAR T cells ever going to be good for solid tumors? Or are they ever going to reach the pinnacle of, I don't know. Hopefully, but
I
yeah, I
think
don't.
we're turning the corner.
We have a
Yeah,
TCR for solid tumor that's FDA
yeah, yeah.
approved.
It's true.
Yeah, yeah, no.
Um,
But then, Chris, so let me press you on this a little bit. So then, over the next few years, what do you think is actually going to matter most in neuroblastoma? Let's just stay with immunotherapy. And don't worry, in 5 years, nobody will remember what you said.
what's going to matter most, or what do I want to see happen, or all of the above?
Both. We could,
Yeah, I, I mean, I'm a big we need targets fan, right? I think we need
Mhm.
to really understand the surfaceome, and you know, GPC2 is just the first thing we picked out of the hat, and I think we'll learn things, and I think it'll become an effective target. And there's multiple trials, not only our own but others going on, and so to me that was maybe the most exciting, just the if you can find new things that you can safely target the amount of research, right? There's so many people doing CD19 and GD2, and there's obviously more than that that's relevant on the tumor surfaceome. So that's, I think we have to keep doing that, but it's not right. It's not trivial, and all these proteins no one knows anything about, and so but I think that's important. But I do think we have to think about smart things like we were talking about, like how to get better T cells. And, if you put a crappy T cell into manufacturing, you're not going to get a good product out. So, we should think about in our world of really just freezing kids. If we're really going to do this, and we know that half the kids relapse and they're going to get a CAR T cell, the economics could work out and collect the T cells earlier. And I think we have to think of as a community that moving these things, forward. And we've even done that just in house and thinking about, all right, well, once you sort of get into a trial and treating patients earlier, even in their relapse course. So, I think that will inevitably make a difference, and the tumor may not be so refractory at that point. Um,
Right.
yeah, so many different things we can do. I think struggle a lot about. I mean, I think clearly we all understand that a single, second generation or even third generation CAR isn't going to be the isn't going to cure patients. And so I think what I struggle is then what do we do, right? Like what is what and we can't combine all these things. We can't make a dual CAR that's armored. That I mean, maybe we can, but it's not trivial. So how do we choose what the next step, best armoring, or, dual targeting strategy is? And I think that's what I have my favorites, but someone else you're going to talk to has their own favorites. So how do we do that in a trial?
Right.
Um,
Exactly.
so
Yes. $1 million question. So the other part of your, the other, I guess, pillar of your research program that we didn't talk about that I read about was monitoring, right? One of my favorite topics. So serial circulating tumor DNA profiling. Do you think, if we're looking what's on the horizon, do you think that will give the field, will it give you just a better chance to follow the evolution of this disease over time, to potentially detect relapse, or the ultimate thing, like, actionable, implement, what do we say, actionable biology earlier? Can
yeah,
it do all of that, or?
yeah, it was so we got into circulating tumor DNA early on, and we convinced this company, Foundation Medicine, to sequence all their patients' blood for free, which was great. So it was like a side project on postdoc, and I think and people are now doing it much more commonly. And there's we built the ctDNA monitoring into our large phase 3 trials, and um, I think the tricky part about that is, actionable is it's a fancy term, but a lot of these aren't actionable in any meaningful way. So, we don't, um, different than Janna's patients, we don't have a lot of actionable mutations. I think it does tell you, at least in the immunotherapy world, if we're going to stay on that, and we followed some of these. We have a clinical assay CHOP now that it's a neuroblastoma specific ctDNA panel where you surely see evolution, right? So, and even evolution genomically post CAR. So, yeah, I don't think that's by chance. I think tumors are smart, and whether there's
Right.
certain genetic, acquired genetic aberrations that whether you see in the ctDNA or somatic sequencing that are driving CAR resistance. I think that's something I've thought a little bit about. And again, there's such heterogeneity, but probably, right? So I think that's one area. But we look a lot of the ctDNA, what to do with it clinically. I think again, it tells you evolution. Does it give you a therapeutic option? Usually not. But I think the getting back to immunotherapy, what we did, and I don't know if I've shown you any of this data, but think of how does a surfaceome change, right? And can you tell? So we live in a world in pediatrics where we don't do biopsies that relapse standard, although we sometimes do them because the parents realize this is really important, and especially as we get more into this, I think we'll probably do more and more biopsies at the beginning of a phase 1 immunotherapy trial. But surely we don't follow biopsy, and so can you do something from the blood that gives you a sense of the surfaceome? So this really great postdoc on I think you mentioned she had this paper in Science Translational Medicine a few months ago where she looked at EVs and extracellular vesicles, and I think we don't. It'll be interesting to see how we use that data, but you can see, extracellular vesicle just sort of phenocopies what's on the tumor, which I think is true. And can you use that data serially to understand how the surfaceome changes under the pressure of whatever immunotherapy? So, it's interesting. But and often these kids have multiple sites of disease. So even if you were to biopsy one, you're not getting, the full antigen picture. So we'll see if
But
that
did you
is something
surveil for GPC2
yeah, we did that. Yeah. So
and
yeah,
ensure that
yeah.
it remains present?
Well, and even can you use it and have a biomarker for the level of GPC2 or the number of GPC2 positive EVs you see, right? Because the EVs are much like your DNA. You get EVs from normal cells, and
Right.
right. So and you can, and they're clearly specific for patients with neuroblastoma. She did those studies where you look at normal kids, and GD2 the same thing. So it's an interesting thought about how to we worked it into our current phase 1, and so we'll get the data from that. But I do think, again, this is not going to be a one CAR cures patients. It's going to be, multiple CARs or multiple dual targeting or combination therapies, and um, and there's some home for it in solid tumors, but I think we still have to find out where.
Great. Well, Chris, this was fantastic. So to summarize, you helped us trace the arc, really, right? From classic multimodal backbone to anti-GD2 therapies becoming foundational, to a much more engineered future built around GPC2, hopefully. I'm a believer. Cell therapy, a little bit of the smarter monitoring and how useful that might be. And also, and this is one of the very many things I love about you, I truly mean this, a very healthy willingness to question old and new assumptions, really. So thanks.
I don't get
And to
for that, but
no, it's true. It's very true. I mean that sincerely. So to our listeners, thank you for joining us for this conversation on neuroblastoma and the next generation of immune-based therapy. And if there's one takeaway that at least I'm getting from this, it's this: the field is not short on clever new tools. And it's going to be very exciting to see what the future holds. But the real challenge now is figuring out which of these modalities actually change the architecture of care. So hopefully we'll have you back in a few years and we can revisit this and see how everything's evolved.
Well, thanks for having me, guys.
All right. So until next time, be well, stay curious, and stay immunological. Goodbye, everyone.